Welcome everyone for another lecture on gynae fellow. We hope this lecture will be very useful and will help you in your day-to-day practice, and also to help you and guide your management for patients who are at menopause or may require HRT. As always, the lectures will be available both on the Gynefellow website as well as our podcast channel, which you can find on Spotify.
So the cover today is going to be pretty much on the practical points and a little bit of science behind what's going on. So what we're going to cover today, we will talk about menopause, different definitions, investigations, if there are any, what is needed, what's not needed. We will talk about the premature ovarian insufficiency. Obviously, we will talk about the HRT, benefits and risks. I'm going to give you practical tips on prescribing and monitoring patients who receive HRT, and then alternative treatments for those who do not want HRT or may not be able to take HRT for various reasons. Testosterone, always a topic in females, and then we get asked about all the time, and then queries and questions if there are any. Menopause is, as you all know, it is the definition of cessation of menstrual cycle. So meno is the month and pause is the ending. And then we have the term perimenopause, and that is defined from the first of the chemical or the physical appearance, which is the absence of the menstrual cycle, to up to 12 months. Before the 12 months, we call it perimenopause. After the 12 months of cessation, we call it post-menopause. From age point of view, the average age of menopause in females in the UK is 51. 80% of women will reach the age of menopause by 54 years old. We use the term early menopause if they get to menopause between the age of 40 and 45. And if they get a menopause before the age of 40, this is when we use the term premature ovarian insufficiency. So the symptoms for menopause, disturbance of menstrual cycle, there are the vasomotor symptoms, hot flushes, and heat intolerance, insomnia, tiredness, irritability, inability to sleep, the swings of mood, the headaches, palpitations, different changes and perceptions to the skin, cognitive functions, starting to forget, formication, which is some form of paresthesia, feeling like there is an insect or something crawling over the skin, the urogenital atrophy and the various urogenital symptoms, and then the relationship issues, which is quite important. I put it here because that's we find it more frequent than a subject that the patients complain about when we do the prophylactic BSO for the various conditions. Now, do we need to investigate all women with menopause to confirm it? The answer is no, and it is age dependent. So if women have the menopausal symptoms After the age of 45, then the absence of the menstrual cycle with the symptoms is pretty much diagnostic, and you don't need to do any lab testing. If they are if they have absence of the menstrual cycle or cessation of the menstrual cycle before the age of 45, then you do the follicular stimulating hormone test. If they are before the age of 40, you cannot call them menopausal until you do two tests of the FSH, and these two tests have to be somewhere between 4 to 6 weeks apart, because it is recognized that the FSH may vary depending on where the woman in her menstrual cycle. Both readings have to be above 30, and if both readings are there, then you call the lady a menopause before the age of 40. Before doing this, also, you need to consider and rule out other causes of amenorrhea, because they simply can be amenorrhea, such as thyroid. You need to check the prolactin level. If women are on contraceptive pills, hormonal treatment, whether it is combined, progesterone, depot, implant, then do not do the blood test, because it's useless. It's not going to help you at all in reaching any diagnosis. So for the premature ovarian insufficiency, again, to confirm the definition, it is menopause before the age of 40. For these patients, unless it is absolutely and clearly contraindicated, which is there are very, very rare indications for that, all women should receive some form of hormonal treatment. This hormonal treatment could be either HRT or combined oral contraceptive pills. And we get asked the question all the time. What do we give here? Do we give contraceptive? What do you think is better, doctor? Do I take the pill or do I take HRT? Actually, both work. And this has been reviewed, and like every one is, there are guidelines about HRT in menopause provided by the NICE. While both are good, HRT is superior to combined contraceptive pill in both reducing the risk of ischemic heart disease or coronary heart disease and osteoporosis. So if you are asked which one would you prefer or advise, doctor, then HRT would be the choice for that. Women who do not receive HRT or contraceptive pill, I will call it hormonal treatment, when they are in the premature ovarian insufficiency, they run the risk of, they are at significantly increased risk of early osteoporosis, congestive heart problems, Alzheimer's, cognitive decline, and neurological diseases. Also, there is a lot of work talking about these women who are genetically prone to have premature ovarian insufficiency, are also, from a genetic point of view, have an increased risk of ischemic heart disease, and therefore the use of HRT is actually could be a life-saving for them. The benefits here of HRT way higher than the risk, and please do not hesitate to give HRT to women. Some, if you are using HRT, they might still ovulate, and then you need to discuss the contraception even with the menopause. It's going to be at some time a confusing subject. From a cardiovascular point of view and HRT in menopause, the recommendation are the following. There is no increase in the risk of coronary heart disease or cardiovascular disease if you start the HRT before the age of 60. Actually, women who have their HRT started within 10 years from the onset of menopause and before the age of 60, they do have a fine kind of a significant protection from the risk of atherosclerotic lesions and cardiovascular problems. This has been proven by a meta-analysis and Cochrane review, which looked at around 23 RCTs in the subject. So while the presence, the use of HRT might be a risk factor with the ischemic heart problem, women should be considered for it when they are optimally when they are optimized before the use of that, even if they have a history. From osteoporosis point of view, it is fairly common problem. 2% of women in the UK, they have osteoporosis before the age of 50. And then when they are at the age of 80, almost 1/4 of the ladies would have osteoporosis. Based on the longevity and how long people live in the UK, 1 out of 2 in women in the UK after the menopause will have a fracture related to osteoporosis. It is well recognized, and you all know that HRT reduce the risk of osteoporosis and the risk of fractures. That risk is reduced after 2 years of using HRT, not before that. So you need to give them a little bit of a time to benefit from the HRT. We advise patients to take calcium 100 milligrams a day and vitamin D when they are in their postmenopause to further reduce that risk. From a venous thrombolism or thrombosis point of view, the subject, because of the previous studies, the subject is a bit confusing. Overall, the following. So oral HRT increase the risk of venous thromboembolic diseases by 1.5 fold increase in the risk. So that's documented and that is known. However, if we are talking about other alternatives of HRT, like transdermal, like the patches or the vaginal estrogen, both of them, they do not increase the risk of thrombosis. The further information, which is quite important, that the type of progesterone that is incorporated into the HRT itself, some of them might have a protective effect for the thromboembolic disease. So the dydrogesterone and the eutorogestrone, both of them are protective. Previous patients with pulmonary embolism or the venous thrombosis, their risk of further embolic disease is quite significant, is 6-fold increase, and therefore oral HRT should be avoided. They should be offered transdermal HRT because that would give them the benefits without put them at the risk of further thromboembolic disease. Next question, you might be asked, how about the cognitive function? The general message there, HRT does not improve, nor that it causes deterioration in the cognitive function. There isn't any benefit, clear evidence one way or the other. So if the objective is to improve the cognitive function, then you should not initiate the HRT, because there isn't really a clear evidence for that. Breast cancer is a very important subject, and there is a lot of literature there which is quite conflicting. Um, the bottom line, it depends on the type of HRT, the type of progesterone, as well as the duration. So the publications, which I'm summarizing here, there was a big study published in the Lancet 2019. There is no increase in the risk of breast cancer at all in all women if the HRT was used only for 12 months. The same types of progesterones that reduce the risk of deep venous thrombosis, actually they found to be reducing the risk of breast cancer if that use was less than 5 years and the relative risk was below 1. In 2008, there was a further big study talking about HRT, different transdermal oral progesterone, and it did not find any significant increase in the risk of breast cancer when it is used for less than 5 years. And this is quite important here. I don't know whether I mentioned that in my slide or here. Why this is important, the duration of using HRT with the breast cancer. It's for us, especially for gynecologists, we find it always when we have to take the ovaries for different reasons, whether it is for a benign condition or risk reduction surgery for BRCA mutation. So in patients with BRCA mutation, in patients who had their ovaries taken for a different reason than a cancer, then HRT should be used until they reach their physiological age of menopause, and that is 50, 51 years old. If the ovaries are taken or failing for a reason related to BRCA mutation, and then like what we do for risk reduction surgery, and that's what the RR-SO risk reduction salpingo-oophorectomy, then we look at the risk for these patients. If their risk of developing breast cancer is high, then we give them HRT for 4 years, because we know that their risk of breast cancer is not increased before the 5 years. And by this, we reduce their risk of ischemic heart disease, the osteoporosis, and all the other risks that we have explained before. If their risk is low, then we treat them exactly in the way that we treat any other woman who doesn't have any risk mutation for the cancer. So, and that's quite important to remember when you are talking to your patients. Further question and further subject that we might be, or you might be asked about, is do you give HRT for women after endometrial cancer? It is an estrogen-dependent cancer. This is the summary or the recommendation from a Cochrane review, which you can find it in the Cochrane library. There is really a very, very low quality or very evident low, there's very limited evidence of a high quality to persuade us one way or the other. But the available evidence from the various studies say that it does not increase the risk of endometrial cancer recurrence. And this is quite important. Why it is important? It's again important because 10% of uterine cancers happen before the age of menopause, and these patients, like if we don't give them HRT, then they run the risk of all the other problems associated with the premature menopause. So even with patients who had hysterectomy BSO for endometrial cancer, the benefits outweighs the risks, provided with the caveat you really need to be monitoring them fairly carefully, and do not just discharge them. How to manage the menopause, moving on from management of the menopause. Um, Obviously, there are different things. So you have the lifestyle, diet, smoking, alcohol, caffeine, exercise, body mass index. All of them has to be taken in consideration. Exercise probably is the most important factor. If you look at breast cancer, it does exercise reduce the risk of breast cancer by 7-fold to 10-folds when in all women. The other factors are obvious, so I'm not going to go through them all. The next part is considering the hormonal treatment, which we explained there, whether you give it as in hormonal natural products or hormonal treatment as in HRT tablets. For patients who are unable to take the HRT, then we treat the symptoms, for example, selective serotonin reuptake inhibitors, clonidine, gabapentin, for the various symptoms. When you should not give HRT, it is in the following. If you have undiagnosed vaginal bleeding, you should know what is the reason for the bleeding before you provide the HRT. Undiagnosed breast lump, that is again another obvious cause. You need to know whether this is a benign or a malignant lump. Pregnancy is a contraindication unless pregnancy happened in the premature ovarian insufficiency, and the HRT is to mimic the ovarian function. Because all the HRT is metabolized, pretty much metabolized in the liver. If you have active liver disease, then you cannot give the HRT. And then active venous thrombosis disease or acute myocardial infarction. We said the oral is the worst condition. So you should not give, definitely you cannot give the oral HRT here. However, if you optimize their condition with the cardiovascular problems and use the alternate like transdermal HRT, then there is a potential reason you can give them once they are optimized. Migraine, similar to the venous thrombosis because of the risk of stroke. So transdermal estrogen is not a problem. Oral estrogen is a bigger problem. Estrogen-dependent cancers, like what I said to you, there is no evidence. If there is an active cancer, which you haven't treated, of course, you shouldn't be giving it. But if you have done the hysterectomy, for example, for the endometrial cancer, and the patient is G1, G2, and there is no evidence of disease elsewhere, then if the benefits outweighs the risks, then you should give it. So this should be individualized, and this is why I left here. There is a but always in these conditions. The HRT could be either cyclical or sequential. It depends on what term you use it. And with the cyclical, there are two types of it, or two regimens, if you want to call it in this way. One of them is the monthly, where you give the estrogen and then you give the progesterone, and then allow the withdrawal bleeding every month. And this use it pretty much in women who had a regular menstrual cycle before, and then they started to have the symptoms. So they never had any irregular period, and they just want the continuation or the management of their menopausal symptoms. And this would be probably the most appropriate if they want to maintain their menstrual cycle. The other cyclical pattern that use the HRT is the 3 monthly regimen, or the 3 monthly pattern, which means you give this estrogen for 3 months, and then you give the progesterone for 14 days, and you allow withdrawal bleeding, like when you do with back-to-back OCP, and you allow bleeding for after 3 months. And that's pretty much for women who had irregular periods before, or they have irregular menstrual bleeding. Because remember, when you give the HRT, there will always be the risk of is this bleeding related to HRT, or is it related to endometrial pathology evolving there? So if they have irregular bleeding, you're probably better off put them on the 3 monthly cyclical regimen, so that you control the menstrual cycle. The alternative to the cyclical type of or HRT is to give them the continuous combined, and that's pretty much what we do in postmenopausal women. Now, and again, the Mirena question gets asked about, can you use the Mirena as part of HRT? The answer is yes. You can use it as an HRT, and then you play around with the different combination depending on the needs. And there are obvious benefits for the Mirena insertion, whether it is in a premenopause or postmenopause, by minimizing the risk to the endometrial cavity. It is obvious that if the woman does not have a uterus, then you do not need the progesterone part of the HRT. So basically, there are so many choices there with the HRT. It's with the cyclical sequential, it's any type of estrogen followed by a progesterone. And depending on the risk for the woman, you need to look and individualize the HRT for the woman, even if there is no contraindication. But if you, when you take the history from your patient, see that there are some risk factors for ischemic heart disease, then the progesterone type is important here. You need to look at what type of progesterone is there, because if that progesterone increases the risk of ischemic heart problems, then you better probably use a different combination that if they want the oral progesterone. The continuous HRT, similar concept to the cyclical HRT, but it's basically the progesterone part is given continuously with the estrogen, and there will be no menstrual bleed or withdrawal bleed with that combination. You can also use estrogen with Mirena IUS in the uterus continuously. You might find the terms of this is ultra low estrogen, or medium or low or high estrogen. So we take the estradiol as 1 milligram. So the ultra low is 0.5, 1 to 2 and 3 milligrams. And then these are the equivalents from the patches of where you need to think. And always when you give HRT, we advise you to start with either ultra low or low unless it is really indicated, because the bottom line, you want to control the symptoms, you want to protect them from osteoporosis and the cardiovascular problems. If you give them higher dose, then you start seeing more of the potential side effects and the potential risks on the long term. Vaginal estrogens, when do we give them, or when do you give them? What are the indications? Well, it is obvious. If they have urogenital tract atrophy, atrophic vagina, atrophic vaginitis, or any condition that, and they come symptomatic from there, then that's how you do it, or that's when you give it. How do you give it to them is you provide them with the low dose estrogen, Avastin or Vagifem, or whatever available in the markets, wherever you are. These are the ones available in the UK. And then they, and you give them the instructions to use it on a regular pattern. It can be used on its own. If the only problem is atrophic vaginitis and or atrophic changes to the vagina, and the patient doesn't need or doesn't want any systematic HRT, or you can give it in combination with the systematic HRT. We always get the question, is that going to increase my risk? No, it's not going to increase the risk, because the systematic absorption from the vaginal estrogen dose is quite minimal, and therefore the impact on the cardiovascular system, the impact on the other systems is quite low. The relief of the symptoms is dependent on the use of the HRT or the local HRT, and if the HRT is stopped, then the symptoms will come back again. Here, caution. We always say it, caution, because as long as you know that there is no evidence to sway it one way or the other, you can give the HRT to the women, but you need to let them know that the evidence is not clear, and also you need to observe them, and you need to also, when you give them HRT, if they have, for example, like endometrial cancer and they have atrophic vaginitis, and this is the only treatment, you give it to them. We always give it to them, but we always say to them, look, if you, especially with the red flags, if you have any vaginal bleeding, if you have any symptoms of concerns, then do not wait for 1 month or 2 months or the time for the routine follow-up to alert us as soon as possible, because we may need to examine you a little bit earlier rather than later. If they are not keen on HRT, and they want something only to relieve the symptoms, if it is only the dryness, then the market has so many products, which is water-based product like Silks, yes, and there are different things. They are pretty much same in terms of gel or water products. When you think about giving HRT and taking the history, or have your consultation with your patient, think about these ones. What is the objective of HRT? If that is premature ovarian insufficiency, then unless there is an absolute contraindication, you should continue until the equivalent to physiological menopause, which is the age of 51, 52. After this, if they want to continue, yes, they can continue. But again, you need to start talking about the risks versus the benefits. Women who symptomatic, even after stopping the HRT, I think it's quite important to continuously weigh the benefits versus the risks. I had patients who are in their 70s, and the minute that they stop their HRT, they cannot cope with the menopausal symptoms, and therefore you balance your decision. And if that is the best decision for them, as long as they know what to observe for, and that and they are well informed, then there is really no reason or hard line when to stop the HRT. Counseling, it's always important. If anything, any message, if all the information that I mentioned earlier, you can find it in the books and the guidelines. But what is important for your exam and your career is always get your patient on board with you. Whatever you do, you need to get your patient on board. The patient needs to be on the same wavelength like you are. You cannot just prescribe it without explaining it. You need to talk to the patient. You need to tell them these are the benefits in the language that they understand, not in the medical jargons. And please be careful with that. So talk to them, let them know what benefits they are going to get and then base your decision with them. Make it like a joint, always a joint decision. While they are on in treatment, always have the holistic and the individualized approach. That goes without saying. We have certain guidelines. The guidelines there are to guide you. They are not a book to just follow. They are to be adopted based on the individual person. Every patient is different, and the circumstances between one patient are completely from the others. Your strategy should be based on the needs for that individual person or that individual patient. And also, it is not a fixed strategy of management. When you are talking to your patient, let's say between premature ovarian menopause, our concern and the patient concern from the beginning was, for example, about the osteoporosis risk, and we want to get them safely to the age of menopause, or the physiological age of menopause, which is the 50-51. After that, maybe their needs are quite different. They might want to stop it and see, and if they develop or they're concerned about the vaginal atrophy or the sexual function, you give them local estrogen. Or they might have developed a disease that kind of hypertension or something, then that adds factor. If they were an oral, you move them to transdermal and so forth. So it is really a dynamic management and communication with the patient, and understanding the patient evolving medical condition and needs is quite important for them. Do you need to check estradiol or their bloods? No, really, not necessarily all the time, unless you are talking about osteoporosis, or you have a concern that they are correspondent to the treatment, because that might sometimes happen. And if it happens, then you need to once you check, you need to play again with the strategy. If they have malabsorption syndrome, then you move the transdermal. If they are transdermal and you started them in the low, and then they are still insufficient, then you go to a bit higher doses, and so forth. How to stop it? HRT is pretty much, it is a hormonal treatment, and it is compensating their needs for that hormone. Do not stop it abruptly unless there is a strong reason to do that. But if there is no strong reason or active condition to indicate stopping abruptly, take it gradual, so that their system gets introduced gently to the reduced dose of HRT. And by this, you minimize the side effects of the HRT withdrawal. Like what we said, the market has alternative.
I would like to remind you, Muayyad, 5 minutes to go, and we are having a few questions as well.
Okay, fine. I don't have that long. So the HRT alternatives, gabapentin, pregabalin, these are for hot flushes. Clonidine is not really that perfect. And then the lubricant that we spoke about. If between all of them, if you ask me what would be the most effective one, it is actually the diet and lifestyle changes would be the most. One of the final subjects is the testosterone. Consider testosterone supplementation in women with low sexual desire. If HRT is not effective, it does benefit energy. It does improve the mood, especially in young patients. And the only approved one is Androfeme in the UK. We tend ourselves to go with the testosterone gel and use it on a weekly or bi-weekly basis.
To summarize, knowledge of the symptoms of menopause, its impact on the patients, as well as the HRT is essential for every clinician, gynecologist, and healthcare professional with interest in the management of female health. Such a knowledge will allow the healthcare professional to offer their patients the best management in terms of short and long-term outcomes without compromising their health. Um, this is all from me with regard to the HRT and menopause. If you have any comments, query, or any questions, please contact us on our platform through our social media, such as Facebook or Twitter. We would love to receive your comments and also receive your contributions on Gynae Fellow. One last word regarding the Gynae Fellow platform, which is a non-for-profit platform with aim to disseminate high quality education all over the world and try to minimize the disparities in training opportunities. And we created the platform as we noticed that clinicians and trainees in particular do find it difficult to find high quality educational resource with emphasis on training. Therefore, we built the app to offer tips and tricks on the surgical skills, while the website offers scientific information on key papers and important subjects, and with the social media, whether it is Facebook, Twitter, Instagram, we offer a platform where we can engage with all our colleagues and patients. Please support Gynae Fellow by submitting your high quality contribution, whether it is a lecture or educational video, key study summary, or even an exam question. Every contribution is important to help the profession and also help our patients on the long term by improving the quality of information and the training worldwide. Thank you, and we look forward to see you again in my next lecture.